Welcome everybody to this OPI Live Education series, The Right Dose. The Right Dose is a professional development series offered by the Ontario Pharmacists Association, designed to connect our members and other pharmacy professionals to high quality learning opportunities and expert minds in the profession. And today's webinar is entitled O-Micron, Answering Pharmacists' Questions Regarding Boosters, Omicron variant, and the safety of COVID-19 vaccines. Thank you for taking the time to join us today. I'm Kathy Tam. I'm the manager of professional programs and education at the Ontario Pharmacists Association, and I'll be your moderator this evening. On today's agenda, I will first provide a brief introduction about OPA and then introduce you to today's speakers, two professionals who will be guiding you through today's presentation. We'd love to hear from you. So you can put your questions in the Q&A box at the bottom there. And at the end of the presentation, there will be an opportunity to ask questions. I'd like to take this time to recognize Moderna and thank them for providing their support and information on this webinar. And for those of you who may be new, OPA is Canada's largest advocacy organization and professional development provider for pharmacy professionals across Ontario. With over 10,000 members, OPA is committed to enhancing the pharmacy profession and excellence in patient care. Right now, we are undergoing our 2022 membership campaign. If you haven't already, please sign up for membership. There is an early bird draw. If you sign up by this Friday, December 17th, you'll be eligible to win one of two Apple iPads. So please go to www.opatoday.com to become a member. And now, tonight's speakers. So we have two speakers tonight. We have Michael Boyven and Dr. Christine Palme. Michael Boyven is a clinical pharmacist, consultant, continuing education developer, and president of ComPharm Consulting, Inc. In 2009, he left full-time pharmacy practice to pursue a career in continuing education and consulting. He has developed in excess of 500 accredited continuing education activities for pharmacists, family physicians, specialists, and allied healthcare professionals. Dr. Christine Palme graduated from the Western University Shoe Lake School of Medicine in 2006, during which time she was granted several awards, including a national scholarship for outstanding candidates pursuing family medicine. She completed her residency at the University of Toronto in 2008 and currently manages a busy family medical practice in Midtown Toronto. Dr. Palme's passions lie in providing comprehensive medical care with a focus on preventative medicine and women's health. She speaks and writes regularly on topics such as immunization and contraception. She was listed as Now Magazine's Best Doctor in 2013, 2015, and 2016, and continues to be a steady presence in Toronto's Best Of list. Dr. Palme was honored by the Federation Medical Women of Canada with her 2016 National Reproductive Health Award. She continues to be active in the media and speaking circuit for public education and awareness regarding many health issues. Take it away, Mike.
Hey. Okay, first and foremost, what a crazy time to be doing a COVID-19 presentation with everything that's been changing. Just today, we saw the announcements. Many of you have, and we'll recap some of the changes that are there. It is wild in terms of what we can see, and I'm going to review some of the data I put through with the help of Christine. We put through this presentation to kind of give you some of the new information of what is coming out that you'll probably see within the next few days. So hopefully I can tell you're in for a treat. Having Christine here on the call, she's going to share with a lot of the practical insights in terms of the education of helping those individual patients that are sitting and coming into you that have those questions that may be burning as well. And I'm going to try to do a deeper dive in terms of the overall data. In terms of the corny name, I love a corny name. Myocarditis is actually what everybody is asking about, and especially with what we saw and happening by Doug Ford today, it gives us an idea of what's happening here in Ontario. So here are Dr. Palme's disclosures. Here are my disclosures. And what we're going to cover over the next hour and a half is we're going to describe the current data on Omicron variant of concern. We're also going to set the stage of what's really happening in Ontario as well. list some of the COVID-19 vaccine booster recommendations, determine which patients should be receiving them today. That also changed today. And discuss the different safety data on COVID-19 vaccines and address some of the common myths that you would see in pharmacy practice. So Christine, let's set the stage. We've talked about this just on a previous webinar just before this. Where are we at? What are we looking for?
Well, in the ever evolving state of affairs, moment to moment, minute to minute, we need to step back, and now we have data as to how we are doing in general. So immunizations being top of mind right now, but let's look at Ontario and cases in the past few days as we approach holiday season. And of note, we're approaching holiday season, a time when people will be traveling, perhaps being a little bit lax with masking. Certainly social distancing is going to fall by the wayside. What's happening in terms of COVID rates, hospitalizations, and with this looming Omicron? It's not all doom and gloom. We're going to be somewhat purveyors of good hope here. But as you can see, the trajectory is going the wrong way. We have a number of cases that are increasing day by day, probably underreported because, symptoms are now nonspecific. People are generally, being lazy about getting those tests. So this is as of today, December 15th, the trajectory is a little bit of a doomsday as we approach this holiday season where our behaviors are going to be the perfect vector for spreading this COVID-19 virus and potentially variant. Next slide. COVID-related deaths, unfortunately, are going up as well. We need to pause. I often talk to patients and people say, we've had plenty of these things, the Spanish flu, the plague, they all fizzled out. And I said, yeah, well, they did, but they also wiped out a majority of the population. And so, that's not our goal. Our goal is to deal with this virus that is here to stay, that doesn't care that it's Christmas. It doesn't care that you haven't seen your grandmother. It's not going to give you a hug, right? It's going to mutate and try its best to spread. And we are the vectors of that. It's our behaviors, our immune systems that are laying way for another explosion ahead. Next slide. Active cases. Why do we need to spend time talking about youth? And I'm going to be talking a lot about vaccine confidence and how to target and have discussions with our patients. So first of all, we just started rolling out the pediatric 5 to 11 vaccine indications. A colleague of ours referred to his own children as little bioterrorists. And that's, the reality. These little kids need to be vaccinated because they are harborers of this virus and spreading them, obviously unintentionally, but it's a huge area we need to target. Then when you think about our older youth, what are they doing? They're getting together, they're sharing cups. I work across the street from a high school, and a couple of the students there are my patients. And when I come out of my office, I see them look at me and then put on their masks. So I know that they're not wearing their masks if they don't think Dr. Palme is watching. So there's a bit of a lifestyle point that we have to address as well. Next slide. So this is fresh off the press. Mike is, I'm the brawn of this presentation. Mike is definitely the brains. He is the go-to person for any sort of data. And looking at recent data related to the Omicron versus the Delta variant, we have an Omicron situation where it's spreading much quicker. And the risk is if we are increasing community spread, what does that mean for our patients who are most vulnerable, our long-term care patients, our immunocompromised patients? Boosters, primary vaccine series aren't necessarily just for us. COVID is unpleasant. I spend a lot of time talking about the silent symptoms of COVID that don't necessarily get picked up by the press. The press focuses on morbidity and mortality in gross ways. They don't talk about the patient who a year after having COVID can't get out of bed, can't go to work, can't provide for their families. So I think we also need to understand that, with a variant that we don't necessarily know a lot about, but we do know that it spreads quickly. We better pick up our sleeves and deal with this, particularly when habits are going to change as Christmas looms ahead, 2 weeks ahead. Next slide.
So Christine, this is such an important point on this one with that RT number. So we look at Delta and we saw what the impact of Delta has been across with an RT of 1.1. 4.29 for Omicron is the estimated here, and it may actually be higher. And from a realistic standpoint, as we talked about in the last one, 100 people that end up developing Omicron variant will spread it to 429 based on the data that's there. So you can see how this is just going to rapidly take hold if it continues at this reproduction rate that we're seeing here in Ontario.
And correct me if I'm wrong, right, Mike, but the RT also sort of takes into account extraneous factors. So lack of masks, it takes the endemic current state into fact. Is that right?
Exactly. So there's R naught and RT. R naught is if assuming that there was no protection whatsoever. So anybody is susceptible, what would that look like? So if it was an R naught factor of 4.29, one person can affect over 4 people. RT is even more terrifying to see this high number because that takes in effect our current population with our current immunization rate, with our current measures that are in place, and we're seeing the spread that's happening at 4.29. So the data here, and we'll see that it's what's happening in the UK. It's terrifying on how fast this is growing.
Yeah, I mean, think ahead. This is sort of the worst time to be having this discussion because we're approaching the holiday season. If nothing else, Thanksgiving, Easter, all those things aren't as big as Christmas and Hanukkah. People, highlight this as the time to actually get together in an authentic way. So who knows what's going to happen with that number when you take those things into consideration.
Exactly.
Okay, so, we talk a lot about COVID ad nauseum, and just previously I was sort of referring to the idea of playing a whack-a-mole. You hit one variant, another variant pops up, but step back. There are other vaccines that are equally as essential. As primary care providers, vaccines are one of the pillars of our care. I always say that good medicine treats disease, excellent medicine prevents disease. So let us not forget about the other vaccines that are really falling by the wayside. We have good Ontario data that adults and pediatric patients are missing, standard recommended vaccines. Tetanus, for example, I can't tell you, during lockdown, people were discovering their kitchens, they were doing DIY renovations. That laceration became a lot more complex to deal with if their tetanus wasn't updated. Think about other vaccines. Shingles, for example. When does shingles erupt? When people are immunosuppressed, when they're stressed, when they haven't taken care of their chronic disease management. COVID. The number of shingles cases that have called into my clinic since the onset of COVID has skyrocketed, which is tragic, right? Because these are vaccine preventable diseases. And think forward, if we don't catch up, if we don't work as a team to address this and educate people, what's going to happen with a measles or mumps outbreak when Omicron comes in, when our medical system is already buckling and is completely flooded? So, we need to take this into consideration. It needs to be a serious discussion, but thankfully we have some ways of doing that. Before the pandemic, you could not throw around words like NACI and CDC. Now it is cocktail party chatter. Patients know about relative risk. They're reading those NACI guidelines. So, the silver lining to this is pause, acknowledge, and say, oh, by the way, since you are so fascinated with COVID vaccines and relative risk and herd immunity and boosters, let's talk about other vaccines that are appropriate for your age group. Next slide. So a study that was put out just early November, multidisciplinary in the sense that involved pharma, involved the private sector, involved all areas of primary care. It wasn't a randomized controlled trial. They just called people on the phone, those telemarketers that you hang up on once you hear that they're telemarketers. And they said, look, did you miss any vaccines since the pandemic started? And the point is these are 100% underreported, because I'm going to show some data that boast to the fact that most Canadians do not know what vaccines they should be getting. So when they call these patients were like, I've totally missed vaccines. 15% of adults admitted, and probably on behalf of their children, 20% of children missed vaccines during the pandemic for a plethora of reasons that we'll go through. So, when the pandemic started, major bodies, NACI, the CDC, said, whoa, we don't know what the next few months are going to look like. Well, the next few months have turned into 2 years, ultimately, if not longer. But vaccines are essential service, right? You can't close your offices. There's some things you can do on Zoom. I can't do a PAP on Zoom. I cannot give a needle on Zoom, but it was hard at that time. We didn't have access to PPE, the concept of virtual care. Access was clearly an issue for patients, and vaccines were definitely a victim. Next slide. So reasons, as a follow-up question, they said, well, why didn't you get your vaccines? And if you remember in March, we were told to stay home. Do not leave your house unless you were looking for food, medicines, or essential medical services. But what was essential? What did the public think that was essential? Vaccines, that tetanus shot, oh, I'll wait a few months, or, oh, I can miss my second shingle shot. It's not necessarily top of mind. And the reality is that primary care didn't necessarily prioritize vaccines. And it's a complex set of reasons. We were scared, we didn't have access, there were safety issues, social distancing. But access to your family doctor's office in the historical way, where you have one doctor open 9 to 5, maybe closed on Fridays, is just not a feasible way of providing medical care going forward. Other reasons that were cited, that they didn't understand what vaccines they were available for, they didn't know where they could get their vaccines. Access is a huge issue that I advocate for. God bless our pharmacists, and I'm not just saying this because we have a pharmacist audience, but we could not have survived last year and the majority of this year without the rallying efforts of our pharmacists in our communities, providing those influenza shots, providing the COVID vaccines. So now when patients are getting their vaccines in TTC stations, in pharmacies, in convention centers, there's now a familiarity that didn't exist before. And as a primary care provider, I am an active champion when I write, particularly a prescription for vaccines that have to be purchased at a pharmacy. So, for example, your shingle shot, they're already there picking it up at the pharmacy. Why on earth would I add an extra appointment unless they needed to come to my office, to just give a vaccine? Get the vaccine there, document it, and I have some tips about that. But open access in a way that matches our current, lifestyle is the way that we're going to, number one, catch up and hopefully change medicine in a way that is more proactive and opens up care to patients who are on different schedules, who have different economic needs. That $1, $2, or $5 subway ride can make a difference for some patients, and it needs to be taken into consideration. Next slide. So this goes to my comment about patients needing education. So when they ask patients, are you up to date for all the vaccines? They say, absolutely. I am completely up to date. My doctor is totally on it. 88% answered positively. The reality is quite the opposite. Only 3% of patients received all vaccines, funded and unfunded, that were eligible for their age range. So in addition to opening up access, we've got an education and an awareness issue. We've got a huge gap. And right now, with vaccination being literally the only issue that most people discuss, included in that discussion, included in that COVID vaccine discussion is, let's talk about other good preventative health care. Let's talk about other diseases that are related to cohort, meningitis B, meningitis C. Let's talk about your influenza shot. When my patients are getting their influenza shots in my clinic, they get a nice handout that they read. Congratulations, I'm so thankful that you're here for your influenza shot. God bless you for taking your healthcare into consideration and those of your beloveds. By the way, here's a list of other shots that you need to discuss. Harness those moments to ensure that a patient gets the correct information. Next slide.
That's great, Christina. And there's so many great points that you have there that it's really about focusing on ensuring this is a holistic approach to immunization. And I know the pharmacists that are on this call are so vaccinated out, and I think everybody in primary care are vaccinated out. It's just that a little bit further to get us through to that finish line. And especially with the changes with Omicron and a variety that are here, it's that continued focus that we're going to have to do moving forward. So I have the pleasure, or I don't know if it's a pleasure, of going through some of the Omicron data that's there and some of the numbers of what we're seeing in different parts of the world, just to give you an idea of what this looks like and why we saw this change in the recommendations for boosters, which I'll talk about as we get to that boostering section. First and foremost, this was basically a picture done by the Financial Times that was coming up and looking at the different mutations that are associated with Omicron. It is very different from what we've seen in the past. There's 26 to 32 different mutations on the spike protein itself, and they're not sure how this is. It's not related to Delta, it's not related to the other types of coronaviruses that we've seen or variants that we've ended up seeing. So it's highly divergent from that component. And there is some data showing that it's associated with a higher risk of escape potential and potential for higher transmissibility. And we'll show you some of the early data as well. Denmark and the United Kingdom, well, South Africa is where they first saw the first initial case numbers. And you can see, looking at the numbers here at the bottom, what that's looked like, really going down, going down, going down. And then really around this time, you can see the numbers starting to shoot up as cases per million. But look at the UK and what's happened there. And then Denmark, which is in green, of how they've shot up over this period of time. So South Africa is unique. And, we've talked about this with different experts, is that they only had approximately 18 to 24% of the people were fully immunized. A lot of the people that actually were ending up getting Omicron were previously infected with Delta or another variant of concern. So we're not sure what that looks like, but I can argue that some of the things that are happening with the United Kingdom within Denmark are more similar to what we have here. And you can see what's happening to those overall numbers and why the changes in terms of the recommendations for boosters. This is London data from today. So this is UK data that's coming up. Give you an idea of the transmissibility of what that looks like. So we mentioned that R0 factor or T factor of 4.29. In London, you can see where Omicron is in purple. It's 51% of the overall cases of COVID that have been reported as of today, and likely will supersede and be the dominant strain within the next couple of days. This is data looking at the share of Omicron variants in South Africa. It's almost 100% of that component. So it's taken that dominant force, and that was just strictly from November 1st to today. And you can see all of the others are starting to increase, whether Botswana is, Spain, Australia, France, Germany, United Kingdom, US, moving forward. So all of it is increasing up, and the data is pushing that in the next 2 weeks, this will become the dominant variant. So this was just released yesterday from the NHS in the UK, looking at the transmissibility of this in comparison to Omicron versus Delta. It is 3.2 higher risk of transmission to household transmission that's occurring. Risk of close contact being a secondary case was double that of what we saw with Delta. And the household secondary attack rate using routine contact tracing with it was significantly higher for these individual patients. It's 21.6 versus 10.7 with Delta. So in the UK, they think that within the next couple of days, it will reach parity. So it's already has that within London. It will probably be in the entire UK within the next couple of days. And what's really scary with this one is it's a higher risk of reinfection with Omicron. So previous variants of concern, if you were actually infected with alpha, delta, alpha or beta variants, you were likely protected well against Delta. And if you were affected with Delta, you were unlikely to be reinfected with Delta. The issue here is that if you had a Delta infection, and the South Africa data is really quite clear on this one, is a good chance that you would have no protection against Omicron and being a higher risk of reinfection. This is data that it's coming out from, this was from Discovery South Africa. It's a health insurer data that came out with a press release. So again, the sources are like Twitter, but this came out in the last little while. So I just wanted to share some of the data that they've seen. They have 3.7 million members in South Africa, and this is the data that they're seeing within their members. So not peer reviewed, not from the standpoint of a broader population, but their population. So what the key things that I want to pull out here is that they found that vaccine effectiveness with double dose Pfizer, BioNTech, it went from 80% with the Delta wave to approximately 33% with Omicron waves versus any type of COVID-19 infection. In terms of severe complications such as hospital admission, it went from 93% for the Delta wave to 70% with the Omicron wave for severe complications. So that seems terrifying. But if you look at when we were, so we mentioned this before on another webinar today, is that today is the anniversary of our first dose of Pfizer BioNTech being administered to a nurse within the US. So we're 1 year at that point. And we can remember that the lowest acceptable weight range that we would give for effectiveness when any of these vaccines were coming to market is if we could get to 30%, we were probably pretty lucky. Or we're still at 70%. So there's a significant from that severe complications in terms of this early data. Now, this is again early, but it looks fairly promising from that overall component. One thing that they did quote from the data as well is that the effectiveness of these 2 doses of Pfizer BioNTech was varying based on the individual age, which is expected. The younger you are, the higher the overall immune response for the patient. So you can see 2 doses of Pfizer BioNTech for somebody who was 18 to 29 likely had a 92% efficacy. But as they got older, when we saw that immunosenescence, that weakening of the immune response, we see a decrease in the overall efficacy. This is, if you're bored and you have nothing else to do tonight, this came out from the White House. They did a forum. This is from the White House forum, but it's Discovery SA data just showing the effectiveness in terms of pre-Omicron, versus post-Omicron versus infection with BioNTech. And again, effectiveness with hospitalization from 93 to 70%. So similar numbers that are there. Vaccine effectiveness versus the UK data, what we've seen here with Omicron and why the panic with regards to the viral vector vaccine. So these would include in Canada, the AstraZeneca vaccine is our primary basis, but also would be Janssen. In other parts of the world, this would include the Sinovac vaccine as well as a Sputnik vaccine. With Omicron, the issue is that it's almost 0% total efficacy against it. So this is why there's this huge worry of what that's going to look like. Now, just to let you know how we differed a lot from the UK is that we used both mRNA vaccines preferentially fairly early within the pandemic in terms of our overall choices, where in the UK, the AstraZeneca, because it was developed with Oxford, was used predominantly for a lot of these patients as well. So they're worried about these patients and needing a booster, but you can see the numbers that are here on the two sides. I know that it's kind of a little bit fuzzy because they took a screenshot from here, but on the left-hand side, this is patients that got 2 doses of AstraZeneca with a BNT, so a Pfizer booster, BNT 162b2 booster. And on the other side is patients that got 2 Pfizers plus a booster of Pfizer. These are the weeks along the bottom. So you can see the efficacy of the overall vaccine decreased the further away we got from the second dose. But when we added on the booster dose, you can see that it actually jumped up quite a bit. And this is why a push to get these vaccines as quickly as we possibly can to reduce the impact in terms of Omicron. This came out from Financial Times today. Again, just looking at overall English data in terms of the efficacy. You can see the vaccine effectiveness for these patients, and then weeks out, it starts to decrease. But relative risk, this is my apologies. This is relative risk of infection. You can see with these patients, it actually drops significantly 2 weeks since the booster. So the booster in terms of the overall basis for both Delta and Omicron seems to be quite effective in terms of looking at that data. Busy slide, but I want to talk you through what this looks like. And this is early data that's coming out that's important. So these are patients that looked at efficacy. So we have alpha, we have beta, we have delta that we're looking here, and then B11529 is Omicron. These are patients that were given 2 doses of Moderna, so Spikevax, and you can see protection against alpha, beta, and delta. But the overall efficacy with just those 2 doses for Omicron within vitro data was not significant. For AstraZeneca, not significant. These are patients that ended up getting AstraZeneca first, followed by Pfizer, looking a little bit better. So there is some data showing that maybe this heterologous type of basis would end up actually offer better protection. And the same thing with Pfizer, still below that level amount. These convalescents are looking at patients that were previously infected. So previously infected with alpha, very little protection. Beta, very little protection. Delta, very little protection. The one thing that was interesting within this group is they looked at the super immune basis. So patients that ended up getting infected, then got a booster dose of vaccine, or ended up getting vaccine and then getting infection. You can see they have robust protection against Omicron. So it's really a strong push for those patients that I had Delta or I had COVID before. I don't need to get the vaccine. For Omicron, this could lead to strong and robust protection to actually protect them over that period of time. More data looking at neutralizing antibodies as well. So looking at the Wuhan versus Omicron, Wuhan beta versus Omicron. Looking at the overall basis, you can see with convalescent plasma, the decrease in terms of efficacy. We see that all of these will decrease over this period of time, just further showing that we need things to bring up our neutralizing antibodies to offer that level of protection. And this is the 3rd dose basis. This paper came out pre-release today, looking at after 2nd dose versus what would happen after 3rd dose. So A here at the top, looking at the overall numbers, what is the level of neutralizing antibodies versus Omicron? You can see they're quite low. But when we booster, it's almost 100 times increase in the neutralizing antibodies after that 3rd dose. And this is why this big push for these boosters to end up happening within these groups. And this was the White House briefing as well, looking at numbers. This is Pfizer BioNTech as a 25 times fold increase in terms of Omicron antibody titers. Protection after the 2nd dose, 21 days, you can see is below the level, the lowest level that we want. 1 month after the 3rd dose, we're above it. So this is that question, and we'll talk about this in the booster. Should we be waiting for an Omicron specific booster? The data here doesn't show that. If we end up giving a specific booster, we're protected against all of these individual ones, wild type, Omicron, Beta, and Delta. So really that focus on a standardized booster for our patients. So this was, again, with a standard Pfizer-BioNTech booster. This was new data that was just released today, and this was done by National Institutes of Health within the US. You can see with the 2 doses, 2 weeks post-dose, many of these patients were above the lowest level of detection in terms of the antibodies. So this is this figure here on this side. Once we do 2 weeks post the booster dose, high levels, very strong protection for patients for Omicron. So this focus on boosters is so crucial, and this is why that announcement came out today. So moving into booster doses. So that was Omicron in a nutshell. Highly transmissible, is going to run rampant and will be the predominant strain within our patients that are here. One question that's coming up is, I've heard that it is not, people will come up to you and say, well, we hear it's not as severe. And that's mainly based on the South African data. As you know, both ICU and hospital admissions and deaths are laggards. So they will come in after the patient has that period of time. So we're going to see this increase in terms of overall infections. What I worry about is that if you have Delta, is Delta being more severe? So you have, if you look at it, the amount of Delta patients, it's like this big, but it's a bigger piece of the pie that are actually getting really sick. Then, okay, well, that's more severe. So we end up having these patients. But with Omicron, there's a potential that we can be this big. Even if it's less severe, it can still be a significant portion of the pie. So I worry about overwhelming our healthcare resources of what this will end up looking like. So we really want to encourage our patients to not believe, oh, I heard it's mild, I want to get it, that's going to be the end of the pandemic. We don't know that yet. And what we do know, and this has been consistent, the more this virus can actually replicate on its own, the higher the risk of getting a mutation that can actually evade more and more of our overall responses. So the key strategy we have to date is not just strictly boosters, but using all the strategies we've talked about before in the past. They're boring, but they work. The masking, the distancing, the hand washing, all make a difference. And we should be strongly encouraging for our patients. So let's go into boosters. What are they indicated for? So booster authorization within Canada on Pfizer was authorized for the 30 microgram dose on November the 9th. The Moderna dose was actually, a 50 microgram dose was authorized on November the 12th. They're indicated for 18 years of age, at least 6 months after the completion of the primary series. So that is the current label for both the Pfizer and the Moderna-based products. So boosters, a busy slide, but this is just basically NACI recommendations that are here. Where they recommended based on NACI is patients 50 years of age and older. So us old people like me, and then looking at anyone in long-term care, anybody who's got 2 doses of AstraZeneca or the Janssen or any of these viral vector components, because we saw what that immunity looked like. Patients in high-risk groups, so in the marginalized communities such as First Nation, Métis, and Inuit communities. Frontline workers, and our frontline workers, like many of you, who were immunized early in terms of the overall course, well, your antibodies may be waning over this period of time, and you really need to get that booster. The booster should be with an mRNA vaccine, and we're not boosting any of our patients with viral vector. The reason why is it didn't lead to as robust immune response, and you could develop antibodies to the virus, so to the bacteria, the adenovirus. Adenovirus you could be developing the antibodies to. Thus, it may not lead to a robust response for our patients. So why 6 months? And this is kind of a silly picture, but this is something that we can end up looking at from a cost effectiveness basis. What we want is a full glass. We want high levels of antibodies for our individual patients. This is really the maximum we can fit within the cup. This is total. If we boost too early, you're boosting at this point, but we're really not adding too much into this one. So that the overall greatness of cost effectiveness or the benefits that we can get from that may not be enough. Whereas if we wait to this point, this may be the perfect time to do that immunization. So not to the point where they're actually dropping too low, but if we top them up, we can get up to that top level. We do not want to wait to the lowest level because this would put our patients at risk prior to boosters. So we really want to look at that optimal time. And originally it was thought to be 6 months would be that optimal time. But as you saw with the announcement today, which some of you may not be aware, is we moved from 6 months to 3 months here in Ontario, and we moved from 50 down to 18 as being that current recommendation because we're worried about what's going to end up happening with Omicron. So do we really need it? That's a question that comes up. And this is data that's come out and has been published. This is from the New England Journal of Medicine. Looking at data, there's a lot going on this slide, but essentially regardless of the age group, for a SARS-CoV-2 infection, the longer you went from the immunization or the earlier you had it, so these are patients 6 months ago, regardless of the age group, you saw that a decrease in terms of the overall protection based on the time that you ended up having. So the longer you had it, the longer since the last dose, the higher your overall risk. And this also applied for patients with severe COVID. But as we know, the complications associated with severe COVID were more common with our patients over the age of 60. So the early people, the sickest people that end up getting it really early are at elevated risk and really need that booster at this point. This is some interesting data that came out. It's in a preprint still. It's Kaiser Permanente data that looking at specifically with Moderna data. And the efficacy here is looking at it 14 to 60 days post the second dose. It's 94% efficacy. And this was when Delta was a predominant strain. So not just when the original studies were done. So when Pfizer and Moderna were approved, it was really in that alpha stage. It hadn't seen Delta yet, but high efficacy for these individual bases. But you can see at 151 to 180 days, that 6-month component, it's down to about 80%. So we see this decrease in terms of the overall efficacy for our bases. So my focus here is that I'm telling people is that, people are saying, well, it doesn't work anyways, why am I going to get it? Our efficacy is actually really, really high, but like everything, whether you have an infection, whether you end up getting any other vaccines, the efficacy will slowly wane over that period of time. So we're likely going to need that additional boost, or we are going to need that additional boost to provide more long-term protection. This is data out of Israel looking at Pfizer specifically, so BNT162b2, and this was patients that ended up getting boosters versus patients that didn't versus their risk of death. Patients that get boosters, you can see their risk of death pretty much is flat all the way across the terms in their follow-up. Patients that did not get their booster, their risk of death actually increased. So just further data to justify why we end up needing boosters. Which one should we get? So that's the key question of the day. Should we be going, if I was Pfizer, should I get a Pfizer booster? If I was Moderna, should I get a Moderna booster? If I was Moderna, Pfizer, should I get, which one of these should I pick? And the data is actually looking at heterologous boosting. And this is just, again, looking at basically antibody levels over this period of time. What do you boost with? So if you're boosting with a Moderna, you're boosting with Janssen, or you're boosting with Pfizer. And what did you originally get? And the key things that I want to pull out with here is that heterologous boosting seems to lead to a more robust response. And it just basically makes sense. You present the antigen in a variety of different ways. It allows the body to lead to higher antibodies. It increases the alarm signals of that component. The other thing that's here is anybody that ended up having a viral vector likely has lower antibodies than patients that had the mRNA vaccines. And that's why mRNA vaccines are being used as that booster component. So heterologous boosting seems to work really, really well. This was further backed up by the COV Boost study that was just published last week. And this was looking at, again, UK patients that got AstraZeneca. And on the things that I want to pull out here is if you gave them full dose of this one, so full dose of Pfizer, you can see the relative increase in antibody levels was quite high. One thing I want to pull out here is that they actually looked at giving half dose. Should we be giving half dose Pfizer? So 15 micrograms as a booster. And you can see that it led to a poor increase in overall response for our patients. So this is one of the reasons why you can see with Pfizer full dose, and this is Moderna full dose, led to a significant increase in terms of the antibody levels in patients that had AstraZeneca. Now, in the UK, they used Pfizer. They didn't have Moderna at the initial component. And the numbers don't seem to come up as why are they not moving as much as we saw with the AstraZeneca? So you saw the big bump here. Why are they not bumping up as much? Is because patients who got Pfizer ended up getting a really good immune response. But then what happens in terms of if you end up boosting at the component? So this looked at Novavax, which we don't have here in Canada, but what happens if we gave an AstraZeneca? We saw some boosting that's here. If we gave this here looking at Janssen, we saw some boosting where these are patients Pfizer. But if we ended up giving more Pfizer, better response. And if we ended up giving Moderna, better response. Half dose led to a lesser response. So this is the reason why the booster recommendations heterologous, so you can mix and match them, should be using full dose of Pfizer. And this was using dosing of 100 micrograms or the full dose of Moderna, which is what they're using in the UK. What about adverse effects? And that's what I think most of your patients are worried about. Like, I felt like crap when I ended up getting my second dose. What's going to end up happening, especially if I'm mixing and matching? And these are kind of cool figures, but really the fundamental thing is that the data consistently in most of the studies that are using boosters, generally all of them are showing that it's about the same. So whatever they had for their reaction with their second dose is likely what they're going to have with this third dose or this booster dose. Soreness of the arm, a little bit of fatigue, a little bit of tiredness. This is typically normal and will be transient and will usually go away within that 48 to 72 hours. Is it a third dose or is it a booster? So in the Pfizer-BioNTech, as I mentioned, it's a 30 microgram dose. That 30 microgram dose is what we're consistently using. So that was for first dose, second dose, as well as third dose. So that is the thought of it being a 3-dose series, similar to what we do for hepatitis B vaccine or Twinrix vaccine, where it's 0, day 30, day 180. Moderna is a little bit different. It's been approved. It's a 100 microgram primary series, 100 microgram, and their booster is 50. So it is truly a booster dose. So it looks like the Pfizer is a 3-dose regimen where the Moderna is 2 primary series plus a booster associated with it. So, should we be looking at, this is kind of a figure I put together. This is a spike protein that's here, but should we be waiting for a variant-specific booster? And the fundamental answer is no. And I showed that in terms of the data. If you give a booster of our current vaccine, we can give good protection against Omicron. And when we think about the spike protein, what we're thinking about, we're going to develop an antibody to the spike protein. But in reality, what happens is that we develop multiple antibodies that come up against the spike protein. So every one of the coronaviruses have at least 1 or 2, to date, have 1 or 2 consistent parts associated with that spike protein. So what ends up happening is you can be developing not multiple antibodies for each of the individual variants, but those 1 or 2 foundational ones that are against all of those ones, so where it's locking into that ACE2 receptor. So if we boost those antibodies, that seems to be enough to offer that protection. And what we saw in terms of the early data, I think it was both Pfizer and Moderna tested an alpha and a beta one, and didn't really lead to much better responses than giving the same vaccine that we were giving originally. So all our data basically shows that we should be really pushing for what we currently end up having and not waiting. And then one of the key concerns that I have with waiting is that we could be 3 to 6 months to half a year to a year before we see a multivariant COVID or SARS-CoV-2 vaccine that could be coming to market. So patients that are waiting are putting themselves at risk. This one statement came up from the White House briefing today. Early in vitro and clinical studies indicate that boosters reconstitute antibody titers, enhance protection against Omicron. Our booster vaccine regimen work against Omicron, and there's no need at this point for a vaccine-specific booster. So what we should be pushing for our patients are not to wait, get in as soon as they possibly can to get that booster dose. What about immunocompromised? Well, immunocompromised patients, these are patients that are not developing as robust immune response. We should be giving them 3 doses as a primary series, at least 28 days apart. And if you're going to be boosting these patients, we should be boosting them with either a full dose Pfizer or full dose Moderna for these patients. So 100 micrograms versus the typical 50 microgram dose. And that may offer a more robust immune response. And for elderly patients, they are also saying if you're going to use Pfizer, it'd be 30 microgram dose. If you're going to use Moderna, likely we're going to have to use that full 100 microgram dose. And as I mentioned, in the UK, they're not even using the 50, they're using 100 microgram doses for all their patients that they're boosting with it. So it gives you an idea of where it sits through. So for most of our patients, the 50 are going to be sufficient, but you're going to start to see some of these people we're going to consider, do we give 100? So if they're older, they have immunocompromising conditions, as well as patients that are elevated risk, they may consider for that higher dose. This was NACI's recommendations for patients age 12 to reduce the risk of myocarditis, and we'll talk a little bit about safety, but they're basically saying that Pfizer seems to be the way to go, using that 30 microgram dose, and we'll show you what that relative risk of myocarditis looks like in comparison to Pfizer versus Moderna in terms of that overall risk as well. But there's preferentially for patients 12 to 29 using the Pfizer over Moderna. So we're starting to see the separation in terms of the 2 mRNA vaccines. The mRNA vaccines for my COVID, looking from a myocarditis basis, it seems to be the Pfizer has a slightly lower risk in some of the data that's come out, specifically looking at Ontario data. But conclusively across the board in our older patients, that higher dose of the amount of mRNA that we're giving in the Moderna vaccine, 100 micrograms versus a 30, seems to lead to a more robust or broader protection for our patients, that which may, especially for our patients really at risk, those elderly patients, those patients in nursing homes, may offer a little bit more robustness that's there. So you're starting to see the separation. We may see some recommendation changes that are actually going to happen. Canadian Myocarditis Review, looking at it, and this was one that was published, and again, you're happy to have a copy of my slides, but they looked at the relative risk. It looks like males under 40 seem to be the higher risk, slightly higher risk with Moderna versus Pfizer, and I'll show you some numbers you can quote with your patients, but it really, the evidence that we have to date does not strongly support preference of one mRNA vaccine over another, even for young males. So I think NACI is being overly precautious because, again, this is the same thing that we saw with a variety of different things in the past. We have an alternative. We could use Pfizer. We don't want our patients to say, I'm not going to end up getting it. This was a really cool review that was published yesterday, and this looked at myocarditis risk, and I'll just talk you through the different figures. So this is myocarditis risk in general. So for patients that are getting CHAD, this is AstraZeneca versus first dose, second dose of Pfizer, first dose, second dose of Moderna, versus having a positive COVID test. If all the patients across the board between days 1 to 28, if you look at 1 million people vaccinated or infected, having a SARS-CoV-2 positive test, it's about 40 in excess of an additional 40 cases per million. Where if you look at Moderna, in the total, this is, again, all the population is about 10 extra cases per million patients. Now, what about those patients under the age of 40? Those are the patients that really people were worried about. Looking at Pfizer, significantly lower risk. So we're looking at 2 to 3 cases, additional cases per million. It's 1 million doses or 1 million infected versus patients infected with COVID. It's about 10 additional cases per million that were infected. Whereas the second dose of Moderna, which is this one here, people are saying, well, I'm really worried about it. But if you look at it, it is 15 additional cases per million. It's a relatively small amount. So I think that's the number, is that people are thinking, well, my son plays hockey, or my daughter is into soccer, or she's playing hockey. I'm really worried about them getting this one. And really, in reality, it's such a small number. And most of the cases to date have been self-resolving, usually just with time, with some minor tape-bases, usually typically treated with something like acetaminophen. So generally, it's been safe. I'm not going to minimize it, but if you look at the numbers in terms of the context of what would happen if these patients end up getting sick, the events could actually be quite serious as well. So I'm going to turn it back to Christine. I went through heavy on the data, and of course, I'm bringing her in here to actually do the really great and practical steps that you can bring in. So I'm going to turn it back to you, Christine, on resources and practical tips.
Your data was, there were a lot of bar graphs, but you have such an eloquent way of summarizing them. And I'm going to be honest, a few of them I'm going to actually show patients. My poor patients, they don't expect a PowerPoint presentation when they come to my office, but such is the state of affairs these days. So you have those patients that come into your office, they have 101 questions, you show Mike's bar graphs, you talk about relative risk of myocarditis, and the risk if a patient develops COVID, what is the risk of developing myocarditis there? The problem is that you're doing this, you're giving them a shot, filling a prescription. I've just told you, you have to talk to them about 20 other vaccines. They leave remembering nothing, nada, zero. So my biggest take-home point is you have to resource patients. God bless the internet. I use it. It's here to stay medicine. It ain't going anywhere. But I sort of compare it to having a library card when we went to libraries. I actually am not young enough that I haven't gone to a library. I still went to libraries, but you go with your library card and you don't know what shelf to go to, right? So providing people with practical, evidence-based, solid information is so essential. These are my information sources for me and my colleagues. I'm going to off record say the Toronto Star has been exceptionally useful. There are rapid COVID updates. Obviously you have to go to the primary source, but 30 minutes before any presentation, I log on to there to find out the latest news. But in terms of accredited sites, these are my top ones. They also have patient portals. I highly recommend that you, log on ever so often, especially with NACI changing their guidelines every day. These are available to you. They're within the slides. Next slide.
sorry, there we go.
Ooh. So top 4 that I recommend for patients. I used to write emails on Monday, sort of summarizing the data, only to hit send and have most of my information be old news. So in the ever evolving state of affairs now with information, I just provide sites that do it for me. Top ones, University of Waterloo and the Center for Effective Practice. They have a patient portal, a physician portal, a whole section for youth. And the 4th site is relatively new. As we have rolled out pediatric vaccines, you got to get schools on board. We have to get our teachers involved. You know, immunizations are a team sport. Educators are part of that. And that's a site geared right towards educators, teachers. They have resources for classrooms. I distribute this to all my teaching patients. Next slide.
Yeah, this is Christina. I just want to do a call out for my good friend and colleague, Kelly Grinrod, who was involved with the University of Waterloo. And I know the work that they put into everything that they put out and how much they run it by patients. They have an entire team of dedicated volunteers to actually look at, from physicians from all over, pharmacists, patient advocates across the country, and helping the resources. A lot of great things here. They did the coloring book and word puzzles for kids. It's been great in terms of that component.
And updated, I feel minute to minute. It's a wonderful resource. So this is also available to you. I've just shown the first page, but this is my summary of COVID-related sites for hot topics. So, you know, the menstrual concerns, like should I get the vaccine when I'm pregnant, when I'm breastfeeding? Those are all in the trenches questions that you get. You need to send patients home with resources. This is double-sided, available to you, print it off, you know, have it available. People can peruse it. You know, obviously information changes. I just updated this last week. I draw your attention to, if you just want to click. So VAX Facts, we are not alone. You know, for those patients with very specific questions. For example, I had a patient who had an allergy before, may or may not have had Guillain-Barré. You know, history is pretty non-specific. She also has anxiety. A complex patient to deal with. VAX Facts is a self-referred call-in center. Patients can speak to either a physician or a nurse practitioner about their vaccine hesitancy, and in some cases get referred. So I had a patient with potential allergy. Through this portal, they were referred to an allergist, received their COVID shots under very supervised circumstances. It's a gift. On the other side of this handout, which I haven't shown, there is a similar call-in service at the hospital for sick children, where patients can actually call in and in many cases get appointments, you know, once again, to, you know, provide those myth-busting appointments, those sessions where patients can actually spend time going through their concerns and get some credible, science-based answers. Really wonderful resources. Next slide. Documentation. So I am a champion. Get those shots in your arms. I don't care if it's in a TTC station. I don't care if it's in a, you know, a convention center. Our pharmacists are champions for this, but let's get rid of those yellow cards. I'm going to go to my grave, making sure that not one single coffee stained, I dropped it in who knows what puddle cards exist. You can't read half the information. You know, handwriting for doctors is not something that's changed. It's unclear what they got, when they got. You've got to peel the layers off. It's COVID, gross, get rid of them. Have your patients download a free app off the Can Immunize site. It's not perfect, but it's what we have. It's coast to coast, so you can put in your province, get updates for what your provincial guidelines are, multi-users, parents can keep track of their information, their kids, you know, their parents' information. Everybody forgets their health cards when they come to my office. Everybody certainly forgets their wallets if they have to pay for non-OHIP notes. Nobody forgets their phones. So, you know, if you have to document, making sure that patient gets their second shot, you know, in cases where co-administration is not an issue, we'll talk about that in a second, but it's one hub that a patient can have. They flash it to you, life is simple. Next slide. So in terms of guidance from NACI, so if you recall, when they rolled out the COVID vaccines, just because they were being a bit cautious and discretionary, you know, that NACI isn't a maverick, they had co-administration guidelines. You couldn't provide another vaccine 2 weeks before a COVID vaccine. There was a 28-day blackout period after the vaccine. You couldn't co-administer except with very rare circumstances. Logistical nightmare. God bless NACI. right before we rolled out our influenza season campaign this year, Massey said, look, it's been a few months. We know that there aren't any safety signals. Go ahead and co-administer. So you can give that influenza shot with the COVID shot. You can update their Shingrix shot. You can make sure that the tetanus is up to date. One shoulder, one tushka, 4 needles, right? We're trying to maximize these visits too. I always say that my consults in office are quick and hygienically dirty, meaning usually they're preceded by phone consults so people know what's happening. We're making sure that all preventative care is done. So, when they're in my office, they're getting their PAP, they're getting their influenza vaccine, they're getting their tetanus shot. And it's sort of an in and out style of healthcare. We're going back to concerns about a very concerning variant. Omicron's back, our masks are on, we want to minimize contact. So God bless NACI, you can co-administer. Next slide. Oh, that's a gloved hand of applause to NACI. So just once again, just a resource list, remind your patients about the call-in sites and be proactive. Mike so lovely reviewed the myocarditis data. Sometimes you have to be proactive in bringing it up. So when I have a patient, perhaps an adult patient, they've already got their COVID vaccines, we're kind of sick of talking about it. I take a moment and say, I remember you have kids. What's their vaccine situation? Proactively discuss this, because it's probably brewing in the back of their minds. Proactively discussed issues related to menstrual changes. The endometrium has receptors. It's an inflammatory piece of tissue. It will react not only to the COVID vaccines, but other vaccines in general. So I always say bust the myth before the myth gets entrenched and ingrained, because it's much easier to do so reactively instead of proactively. Next slide. And this is my handout, once again, available to you. My poor patients have so much reading to do. So while they're waiting, for their time period after the influenza shot, 6 feet apart from everybody else, they're not necessarily using their phones, they're reading this. Thank you so much for coming into my office and making your health a priority and getting a vaccine that's not only for you, but to protect the public. By the way, here are lists of other vaccines that I've likely talked to you about ad nauseum, but you're sitting here. So let's talk about them and read about them again. Next slide. Whenever I speak about immunizations, this is one of my key slides. So when they asked doctors, this was a study on doctors, but I'm going to extrapolate to healthcare providers in general in primary care. Why do you think a patient didn't receive a vaccine? Cost was top of mind. They weren't interested. Well, they're vaccine hesitant. I've already talked to them. I just gave them their tetanus vaccine. A list of reasons. When you asked a patient, and it didn't matter who the patient was, it didn't matter what vaccine. When you asked a patient why they didn't get a vaccine, they said, nobody talked to me about it. So, in the spirit of holiday gifting, one of the gifts that we have as primary care providers is the confidence, of our patients in the advice that we provide. In terms of what belongs to primary care, my diabetes patients often see endocrinologists, my cardiac patients perhaps have cardiologists. I may be the only person a patient actually has a discussion with about a certain vaccine. So this is a gift, it's a privilege, it's exhausting, certainly as of now, but that call that comes in 4:30 on a Friday, inevitably, for a patient that wants to talk to you about a vaccine, you have to take it because our role really does make a difference. Next slide.
That's our last slide.
Yeah.
So that's great. So I think the key things here is one thing we didn't mention. I didn't include it because I wrote this just before the press release. So as we saw, 18 plus for boosters, down to 3 months instead of 6 months as being the key will be the recommendation. They are concerned about Omicron. They want to ensure that patients are topped up to have that protection. I think that one of the key things that we want to also focus on, both of us, Christine and I work with Peter Lynn a lot. He talks about everything as being hockey terms. The vaccine is the goalie, the defenseman is going to be the mask, and the forwards are the distancing, keeping the puck away from the goalie. So we want to encourage our patients, especially during this time of year, to be really careful.
I use the analogy of, upgrading your system. You have an operating system. In order to have the apps working, you always have to update it. Otherwise, your computer goes defunct. So, we suspect that there's other shots forthcoming, but you've got to update, you've got to boost.
That's great. We have just a few questions and we'll go through those, and then if anybody has anything else, we can put it in the Q&A. So the first question that's come up is, should people with Astra and Moderna receive Pfizer then as being more effective, as the first one? So patient has had AZ first, followed by Moderna. Should they get Pfizer? So we talked about this, Christine, on our last webinar that we ended up giving. My biggest concern, so I'm a Moderna person, so I went Moderna. That's what we had from public health. And when I went, I saw 4 couples all over the age of 70 said, ooh, I don't want to get that Moderna one. I'm going to refuse. My biggest concern right now, more than anything else, is that these patients are at elevated risk. We need to get patients protected. So I think that the key thing here is I wouldn't want the patients to fuss over what they end up getting. They should be either getting an mRNA vaccine, be it Pfizer or be it Moderna. They should get it as soon as they possibly can, based on the recommendations that we have out in Ontario. Next question is, so why are we giving 50 microgram Moderna then if it's not effective? That's not the case. 50 microgram Moderna is actually quite effective. It is not as what we're really concerned about in patients who are immunocompromised and patients who are elderly, who have immunosenescence, so not that immune response. They don't have that robust immune response. For a lot of the young people, like Kathy, who's on this call, and like Dr. Palme, who's on this call, 50 micrograms is going to be more than enough to actually offer that boosting type of basis. But it's for our older patients and our patients who are at elevated risk that we may end up wanting to consider that full dose. So the 50 micrograms of the Moderna dose is the approved booster. We just, in some cases, we may use that higher dose. And like what we've said before, is that everything is changing. So, you know what, there could be difference in terms of our recommendations of what we're doing today versus tomorrow versus a month from now. Don't worry, as more research and more data is coming out, we could adjust this further. But at this point, 50 microgram dose is quite effective.
Here again, we have sort of the mixed combination of first dose at AZ, second dose Moderna, booster, preferred Moderna or Pfizer. Do they want the holy trinity for future travel? The reality is that there's no preference right now. Mike specifically said that just get a needle, whatever is available. I'm a Pfizer lady, right? And there wasn't an option for me to have Moderna or Pfizer. And I just said, just put it in my arm. I don't really care.
Yep, and that's exactly it. It's really what we want is get the dosing in as quickly as we possibly can. Early non-Delta infection, 2 Pfizer vaccines, still waning antibodies, still booster against Omicron. So this is a patient that's had infection, had 2 Pfizer vaccines. Do they still have waning immunity? Do they need protection against Omicron? And the question is, we really don't know. Like these are the super immune patients. So patients that were previously infected that ended up getting the vaccine likely would have protection. But for this specific patient case, from a holistic patient point of view, should we be dosing this patient? Probably. I would probably still consider that individual. I don't know, Christine, what would you think? The data, I don't have any data that would say otherwise, that I think this patient should probably get the dose. There's very little risk associated with it, and they may not be protected, but I don't know what you think.
I mean, I think that understanding that you'd have to preface saying we don't necessarily have the data. We also don't have necessarily data about Omicron. So with the low risk situation, we went over the data about the safe, really no safety signals. If this were me, I'd be rolling up my sleeve.
Yeah, that's great. And super immunity. These are the super immune. I love the terminology, but these are patients. Super immune patient are like this woman that we were just talking about in the last question. It's a patient that's had previous infection and had the vaccine, or had the vaccine and then infection. These seem to be super immune. So these patients that have had this combination of infection plus vaccination are at have super immunity, which would put them at lower risk of developing Omicron. But we don't know what that level of protection. These were in vitro studies. So looking at convalescent plasma, looking at patients that, and looking at the specific vaccines. So I would still want those patients to be boosted, like I just mentioned, because again, low risk, but and really still learning in terms of what Omicron is going to look like. So I think it's really important that we end up protecting at this point. And I think we got them all. Kathy, I think we got every question that came up.
Yeah, I don't think there's any more questions. Maybe give people a few more seconds if they were still trying to type something out there.
Well, while they're doing that, I really want to first and foremost thank OPA for allowing us to come up and to talk about this one. It couldn't be a worse time or a better time to be talking about COVID with all the changes that have happened over the last few weeks. I want to thank my colleagues, all these people that are on the front line that have been doing so much. I know how tired you are. I know how overwhelming this is with everything that's going on. And hearing about Omicron is kind of scary and just like, I can't believe this is happening all over again. You guys are making such a huge difference. You really can do a lot here. I also want to thank you for giving up your time. I know you're tired to come in and hear this one, and hopefully we're able to increase your knowledge. And I also want to thank my co-presenter, Dr. Christine Palme. Obviously, there's such a great tips here that you can utilize within your practice starting tomorrow. So thank you everyone for coming in tonight, and then I'll turn it back over. I don't know, Christine, if there's anything you wanted to add that I missed.
And just, being in the trenches too, vaccine, but don't forget about the masks, social distancing. It's unpleasant. We just want to hug people because it's Christmas. We simply can't. Eventually we will, but I always say COVID doesn't have feelings. It doesn't have a heart. It doesn't care if it's Christmas. So we as a community still have to rally ahead. There is effort. There is success in being a team. So God bless for everybody who's listening. Pharmacist colleagues have made such a difference to the primary care landscape. So thank you so much for your work.
Thank you both. And actually, one question did come in while you were saying your wrap up. Are all the studies of waning immunity looking at antibody levels only? What about memory?
Memory is a great question. So we have no really measures of what is happening in terms of T cell memory overall. So I don't know. But if you look at the data of what we've seen with most of the studies is that the real world evidence is supporting that if we actually don't booster, these patients are at elevated risk of infection and at elevated risk of serious complications associated with it. So the real world evidence is not just looking strictly at immunity, but just infection rates and complication risk. So yeah, that we don't have anything specifically in terms of looking at overall memory, but with that real world evidence supports that overall need for those boostering.
Thank you. And I think that's it for the questions. So on behalf of OPA, thank you, Mike and Christine, for joining us today on what is a very obviously timely topic, but difficult to kind of keep on top of everything. So I really appreciate you putting this together, and I'm sure everybody here has learned something and can take something back with their patients. And thank you all the participants who showed up today. I know you're all very busy as well. And I do have a survey at the end of this, so please also fill it in so that we can further meet your future professional development needs at OPA. Thank you, everyone. Have a good night.
Thanks, everyone. Take care. Have a happy holiday. Bye-bye now.